Let's talk about how to abstract physician documentation, because in this documentation is where you will find the key terms or the main terms from which you will determine the codes. The most efficient and effective way to do this, and actually required by law, is for you to read the entire documentation, whether it's an op report that's 5 pages long or whether it's a progress note that's 3 sentences. The truth is that the law requires you to read the entire thing, and it's really a good idea to read it twice. Now, as you begin to do the job of coding, or the coding process as we call it, as I just said, you need to read the notes completely, and it's really recommended that you do this twice. The first time you read through the entire encounter notes just to get the full idea of everything that occurred during this encounter. Then you go back and you read it again, this time thinking about step number 2, as you see on your slide, which is to begin to identify the key words and phrases that will point you toward the information you need to determine a code. Now, step number 3 is kind of weird, and the reason I say that is before you can actually finish your job of coding, you need to identify anything that's missing, incomplete, or confusing, and query the physician. This is not a moment of weakness. This shows your knowledge, not your lack of knowledge. But it's very important that you get clear documentation that is complete. Now, the reason I say it's weird here in the 3rd spot is some of the time, maybe even a lot of the time, you don't even know that something is missing until you get to actually looking up a code. And then you may see that the code requires an additional character, or a different code says this or that, and you don't have that detail in the documentation. So querying the physician may occur at anywhere during your coding process. But remember, and I'm going to say it again, when you query the physician to annotate the documentation, this is not showing the physician disrespect at all. This is not showing your supervisor or the physician that you don't know what you're doing. It's the exact opposite. It's showing them that you do know how to code accurately and that you do know what is necessary to determine a correct code. And this also will help you avoid reporting any unspecified codes in ICD-10-CM. Okay, so now you're going to proceed and you will code the diagnoses, signs or symptoms as documented depending upon their relevance. The same thing goes with procedures, services, and treatments. Now, I want to point out to you that the documentation is not written for us, for coders. It is written for continuity of care and many, many other purposes. We are just among a group of people who use this documentation. What does that mean to you? That means that there are going to be details in this documentation that are not relevant to coding, that do not get coded. Okay? That's part of your job in abstracting, is to identify what is relevant and needs to be coded for this encounter and what does not. Okay, so then you have to remember that every encounter must have at least one ICD-10-CM CM code and at least one procedure code, because no patient goes to see a doctor or no doctor goes to see a patient for no reason at all. And if the physician is there and sees the patient, then the physician is doing something. Now, that one code may be an evaluation and management code. I'm not saying every encounter includes surgery or some type of procedure or treatment, but there should be at least an evaluation and management code for the physician. So you must have at least one of each. And every procedure must be justified by at least one diagnosis code. So there has to be at least one diagnosis code that identifies the medical necessity for whatever the physician did, including evaluation and management. Always, always, always double check your work, okay? Go back and double check the codes from the coding manual, or if you're using an encoder, it doesn't matter. But remember that we all get occasional, I call it finger dyslexia, okay? You know, where you're typing in a phone number, for example, and you accidentally type in two numbers in the wrong order, okay? All of our details, especially in the codes, everything must be accurate, 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 accurate. Okay? And it is much better for you to catch your own mistakes and fix them than for the third-party payer to identify your mistakes and deny the claim, or for the government agency to identify your mistakes and come audit your facility. Okay, so this is a habit you want to build right now, starting right this second. Double check your work. And this is not only for just coding, this is for everything. You need to check your spelling, you need to check your grammar, you need to check that what you're saying, what you're writing is expressive of what you're trying to say, what you mean to say, and that includes the codes, because one number difference is a huge deal. Okay, and as I mentioned before, the diagnosis codes explain the medical necessity. Now, of course, I think we all agree that nobody wants a physician of any kind to perform a procedure or service or treatment on a patient without a good medical health-related reason to do so. If you know what a colonoscopy is, I don't think you want to volunteer to have a colonoscopy just because your doctor's Jaguar payment is due next week. Okay? So, it is our job in health information management, and particularly the coder's job, to make sure that everything is justified. And therefore, you must make sure that the diagnosis codes are there to state emphatically that the provider was acting in accordance with the standard practices known as the standards of medicine. So the diagnosis codes have a lot of work to do, okay? They are there to explain why the physician provided the treatment, the medical necessity, okay? They are there to explain why the patient needed that service or treatment or procedure. And in a lot of cases, almost all of them, the diagnosis codes explain why the insurance carrier should pay for it all. That's a lot of work for that little diagnosis code, and that's why they are so incredibly important. Diagnosis codes explain diagnoses, signs, and symptoms, in addition to reasons why healthy patients would go to see a doctor. Can you think of something? Okay, how about when you go to the doctor, you feel perfectly fine, but it's time for your annual flu shot. You're perfectly healthy, and you get the flu shot to keep you healthy. That's known as a preventive service. All of those are reported with ICD-10-CM codes. Procedures explain what the physician did for the patient. Now, when you're reporting for the physician himself or herself and what they did, you will use CPT codes to explain that, no matter what the location. CPT codes are also used to explain the services provided by an outpatient facility. So this might be a walk-in clinic, this might be a same-day surgery center, or it might even be the outpatient procedure center within a hospital. CPT codes are also used to report the services provided to a patient at an emergency room. HCPCS Level 2 codes are the what else, okay? What else did the physicians provide or the facility provide? This may be supplies, this may be medication administered by a healthcare provider. There's a whole lot of things, and you'll learn more about HCPCS Level 2 codes. And then we have ICD-10-PCS. ICD-10-PCS, Procedure Coding System, reports what the hospital did, the participation from the hospital in procedures provided to patients who have been admitted to inpatient status. Now, when you look at the documentation, you will see that they can take many different formats, okay? Very often in a physician's office, physicians will use what are known as SOAP notes. And the SOAP is an acronym that stands for Subjective, Objective, Assessment, and Plan. SOAP. Subjective is what the patient reports the physician. Why are you here today? This is also known as part of the chief complaint. It may also include the history of the present illness and any relevant history of the patient. Objective is the part of the documentation that reports the physician's objective observations from a physical examination. You know, where they take their stethoscope and they listen to your heart and your lungs, and they take that little thing and they look in your eyes and your ears and up your nose and down your throat. Also in objective will be vital signs, as well as any test results that are available and discussed during this encounter. The assessment is essentially the diagnostic statement. This is the physician's determination of what is going on with the patient. This may be confirmed diagnosis, or it may be signs and symptoms that support the plan, which is coming up. The plan is going to explain what the physician wants to happen next. Narrative notes are dictation, very often used by specialists because they include an update only. Remember, specialists typically focus on one particular issue or diagnosis of the patient, and when they see a patient, particularly one with a chronic illness, on a regular basis, their notes will only be interval notes, which means they will just say what is observed this visit, this encounter, and will only go back as far as the last visit. And then we have procedure notes or operative notes, which are actual specific details as to what went on during a procedure or a treatment or a surgical event. All right, so when we read the documentation, we must be very careful, as I told you in the beginning, to pick out the words that are relevant to us as coders and ignore everything else. And this is important, and it's not so easy. So let's take a look at this very short little documentation. Sally Ann Carter, a 17-year-old female, came to see Dr. Washington with complaints of arm pain. After a history and exam, he took an x-ray and diagnosed her with a green stick fracture of the ulna, right side. He applied a cast. Okay, well, that's nice and short and sweet. So now let's take a look at how we identify what we as coders need to know. And I strongly recommend that you do this in process. And what I mean by that is focus on only the diagnosis keywords and code those first, then go back and focus on the procedure. But we're going to kind of do everything here. So as we read through, we see the physician performed a history and exam. He took an x-ray and he applied a cast. And those are all things that the physician did. So we know that those will be reported using a procedure code because they explained what the physician did. Then we see the diagnostic statement, diagnosed her with a green stick fracture of the ulna right side, and that explained why the physician did all those things for her, right? So those will be reported in diagnosis codes. Now let's take a look at missing information. Did you think anything was missing? Well, as you go through the coding process, you will find out because the ICD-10-CM codebook will tell you what's missing. So as you go and look to see the fracture of the ulnar bone, you'll see that an additional character is going to ask, well, exactly what part of the ulnar bone was fractured? An ulnar bone, which goes from your elbow to your wrist, is what is known as a long bone. And medically speaking, it is considered in sections. So we have to query the physician and find out which specific part of the ulnar bone was fractured. Now, you certainly don't want to report an unspecified code here because that makes the physician look like an idiot. And we're sure he's not an idiot, okay? How could you know a bone is fractured and look at an x-ray and not know what part of the bone is fractured, right? Okay. We will also need to know how and where she got her injury because we'll need to report external cause codes. So we have to go back to the physician, or you might even need to contact the patient to find out how she broke her arm. Oh, she fell off a ladder at home. Okay, now we have that added to the documentation. Now here we have again what was in the documentation. Diagnosed her with a green stick fracture of the ulna right side. Which word explains specifically why she needed care? Can you figure it out? It's the word fracture. And green stick is a type of fracture, and ulna is the anatomical site of the location of the fracture. And as we learned and had added through our query of the physician, specifically the shaft of the ulna. Okay, so do you see how this one diagnostic statement breaks down, which is important for you to identify these parts because that's how you will look it up in the ICD-10-CM code book. We will go to the alphabetic index because the code book is very big and contains a lot of codes, something like 68,000 codes, okay? So where are you going to find the codes for fracture? Well, you go to the alphabetic index and turn to our first keyword. Why did this patient come and need care? And that's because she had a fracture. So you look and find the word fracture, and below this you're going to find a long list of terms. When you look at those terms, you're going to notice that they're, for the most part, anatomical sites that you learned about in anatomy and physiology class. So go down and look for our anatomical site. Remember, the anatomical site that we found is ulna. And so you're going to go all the way because it's in alphabetical order. So U is all the way at the end of the alphabet, okay? So you look down the long indented list under fracture, you find ulna and find ulna shaft. And that suggests a code. And you'll see it says S52.20, and there's a little hyphen there. And that tells you that you need additional characters. But that's okay because those additional characters and what they mean are in the tabular list, and you have to go to the tabular list before you can determine any code for certain. So we are going to go ahead and take this suggested code, and now we are going to go to the tabular list. The tabular list has all of the codes, all of the 68,000, however many codes there are in this code set, in alphanumeric order. So we start with A0. So S52 is going to be all the way, keep going, keep going, keep going. Okay? And you always start with the first 3 characters because there are notations and there are symbols, and that's the book's way of telling you details and hints to help you determine the correct and accurate code. So it would be silly if the book is trying to point you right to the correct code. It would be silly for you not to listen. Although you're not really listening, you're reading, okay? So take your time and read carefully and read everything. Okay, as you look below S52, fracture of forearm, you're going to notice that this does require a 4th character. And remember that in ICD-10, there is always a dot between the 3rd character and the 4th character. Always, always, always. Okay? And so that brings us to fracture of shaft of ulnar. Yes, that's what the doctor said. That's what was written. Remember? Okay, but now we require a 5th character that asks what type of fracture. Oh, go back to the documentation. And remember, the documentation did tell you what kind of fracture, a green stick fracture of the shaft of the ulna. So now we have our 5th character, S52.21. Excellent. There's a symbol there that tells you that this code needs a 6th character. And it's asking you which arm. Okay, that was also in the documentation. So go back to the physician's notes and you will see S52.211, green stick fracture of shaft of right ulna. Look at how you're building this code and you're coming and it's matching the documentation. Isn't that cool? Okay, but wait, we're not done yet because there's a symbol there that says you need a 7th character. Well, what's left to say? Where in the treatment plan are we? So when you look at what the meanings are for the 7th character, you will see that this is subtly but identified in the documentation. This is the first time that this patient is seeing this physician for treatment of this fracture. So you will use the letter A as the 7th character, and this tells the whole story in one code. S52.211A tells the whole story about why this patient needed the care of this physician at this encounter. Because she had a green stick fracture of the shaft of her right ulna, and this was the first time the initial encounter for this closed fracture. Oh, you didn't know a green stick fracture was closed? It's okay. Look it up in an anatomy book or look it up in a medical dictionary. So, To be precise, well, we're not going to get into external cause codes here, but whenever there's an injury or a poisoning, we are also required to explain how the patient became injured and where the patient was when she was injured. And so you will see that you'll need a minimum of these 3 codes to report the whole story as to why the patient needed care from this physician during this encounter. Okay, does that make sense? All right, so I just want you to know that a lot of the case studies we use in this course and that are used in teaching coding are actual real patient records. So they're going to give you a slice of reality, because physicians do not always include all the details that you need to determine the code. Remember what I said in the beginning, they do not write documentation for us, and they don't know how to code, so they don't know what little detail they may have. Oh yeah, okay, I forgot to write that, but we need that. Okay, so therefore remember that querying in the physician is part of your job and legally required. Now, while you're in class, query your instructor. But when you're on the job, you query the physician who wrote the documentation, okay? Excellent learning. If you have any questions, just ask your instructor or post to the Q&A with the professor discussion here in this course.